Welcome to Diabetes Basics, what key personnel need to know. The school nurse, when available, is the most appropriate person in the school setting to provide care for a student with diabetes. However, many schools do not have full-time nurses. Even for schools that do, the nurse may not always be available at all times during the school day, during school-sponsored extracurricular activities or field trips to assist with routine care and emergency care. Trained school personnel must be available to perform and assist the student with diabetes care tasks. This presentation is not intended to provide legal or healthcare advice. Please consult with a legal or healthcare professional regarding your specific questions or needs. Each training component was created specifically for school nurses and other qualified healthcare professionals to train school personnel. These components include diabetes basics, diabetes medical management plans, hypoglycemia, hyperglycemia, blood glucose monitoring, continuous glucose monitoring, glucagon administration, insulin basics, insulin by syringe and vial, insulin by pen, insulin by pump, ketones, nutrition and physical activity, after-school programs, sports and camps, before and after school care, child care, psychosocial aspects, legal considerations, and type 2 diabetes. The objectives are for participants to be able to understand what is diabetes, why care at school is required, basic components of diabetes care at school, short and long-term consequences of diabetes, recognition and treatment of hypoglycemia, which is low blood sugar, and hyperglycemia, which is high blood sugar. Here are common statistics about diabetes. In 2019, 37.3 million Americans, or 11.3% of the population, had diabetes. Nearly 1.9 million Americans have type 1 diabetes, including about 244,000 children and adolescents. 1.4 million Americans are diagnosed with diabetes every year. About 283,000 Americans under age 20 are estimated to have diagnosed diabetes, which is approximately 0.35% of that population. In 2014 to 2015, the annual incidence of diagnosed diabetes in youth was estimated at 18,200 with type 1 diabetes and 5,800 with type 2 diabetes. Diabetes is a chronic disease in which the body does not make or properly use insulin, a hormone that is needed to convert sugar, starches, and other food into energy by moving glucose from blood into cells. People with diabetes have increased blood sugar levels for one or more of the following three reasons. Either little or no insulin is being produced, insulin production is insufficient, and or the body is resistant to the effects of insulin. As a result, high levels of glucose build up in the blood and spill into the urine and out of the body. The body loses its main source of fuel and cells are deprived of glucose, a needed source of energy. High blood glucose levels may result in short and long-term complications over time. Type 1 diabetes is an autoimmune disorder. In type 1 diabetes, the immune system attacks the beta cells, the insulin-producing cells of the pancreas, and destroys them. The pancreas can no longer produce insulin, so people with type 1 diabetes need multiple daily administrations of insulin to live. Type 1 diabetes can occur at any age, but the disease develops most often in children and young adults. Type 1 diabetes accounts for about 5 to 10% of diagnosed diabetes in the United States. The symptoms of type 1 diabetes usually develop over a short period of time. They include increased thirst and urination, hunger, weight loss, dry skin, and sometimes blurred vision. Children may also feel very tired all the time. If not diagnosed and treated with insulin, the person with type 1 diabetes will eventually lapse into a life-threatening condition known as diabetic ketoacidosis, or DKA. Though scientists have made much progress in predicting who is at risk for developing type 1 diabetes, they do not know exactly what triggers the immune system's attack on beta cells. They believe that type 1 diabetes is due to a combination of genetic and environmental factors. Onset in children has a variable time frame. Some children develop type 2 diabetes rather quickly, others more slowly. Some symptoms are often similar to type 1 diabetes: tired, thirsty, hunger, and increased urination. Some children show no signs at diagnosis. Others are symptomatic with very high blood glucose levels. Type 2 diabetes is the most common form of diabetes. In type 2 diabetes, either the body does not produce enough insulin or the cells ignore the insulin. In type 2 diabetes, either the pancreas is unable to make enough insulin or the body cells have become less responsive to insulin, a condition called insulin resistance. With insulin resistance, the body needs increasing amounts of insulin to control blood glucose. In response, the pancreas tries to make more insulin, but sometimes cannot make enough. Type 2 diabetes used to be found mainly in adults who were overweight and over 40. Now, as more children and adolescents in the United States become overweight and inactive, type 2 diabetes occurs more often in young people. Type 2 diabetes is more common in certain racial and ethnic groups, such as African Americans, Hispanics and Latinos, American Indians, Alaska Natives, Asian Americans, and Pacific Islanders. Other risk factors include having a mother who had diabetes during her pregnancy. Diabetes is managed with medication, nutrition, physical activity, and glucose monitoring, but there is no cure. When the body doesn't produce insulin, it must be obtained from another source. All people with type 1 diabetes must take insulin by injection to live. Many people with type 2 diabetes take glucose-lowering medications, which can be taken orally or by injection. Many youth with type 2 take insulin, often in addition to other glucose-lowering medications. People with both types of diabetes also need to manage their diet and physical activity. Neither insulin nor other medications, however, are cures for diabetes. They only help manage it. With both type 1 or type 2 diabetes, the goal of effective diabetes management is to manage blood glucose levels by keeping them within a target range that is individually determined for each child. Optimum blood glucose control is essential to promote normal growth and development and allow for optimal learning. It also prevents the immediate dangers of blood glucose that is either too high or too low. Additionally, research has shown that maintaining blood glucose levels within the target range can reduce risk or delay the long-term complications of diabetes, such as heart attack, stroke, blindness, kidney failure, nerve disease, and amputations of the foot or leg. While it is important for school personnel to be aware of the potential for these serious life-limiting or life-threatening complications, it is not appropriate for school personnel to discuss risk for complications with individual students. A Diabetes Medical Management Plan, or DMMP, should be implemented for every student with diabetes. This type of plan might go by a different name in the school districts or by some healthcare providers. The DMMP is developed and signed by the student's personal healthcare team and parent guardian with the specific needs of an individual student in mind. It should detail the elements of care and assistance for that student. Once the DMMP has been provided to the school, it is implemented collaboratively by the school diabetes team, which includes the school nurse, the student, the parent or guardian, and other school personnel. Details regarding how, when, and where and by whom the elements of the DMMP will be implemented should be documented in writing. Many school districts have their own health forums where the school nurse documents information on diabetes care. Additionally, both health and academic accommodations related to diabetes should be included in broader education plans for students with disabilities. For example, under Section 504 of the Rehabilitation Act of 1973, students with diabetes are entitled to accommodations to ensure equal access to public education. A 504 plan should be written to document diabetes-related accommodations needed by an individual student. Some students with diabetes will also be eligible for special education. For these students, diabetes care needs should be documented in the IEP that is required by another federal law, the Individuals with Disabilities Education Act. Maintaining blood glucose control is a juggling act, 24 hours a day, 7 days a week. Many variables affect blood sugar. The key to optimal diabetes control is a careful balance or juggling of food, physical activity, and insulin and/or oral medication. As a general rule, insulin and oral medication and physical activity makes blood glucose levels go down. Food makes blood glucose levels go up. Several other factors, such as stress, illness, or injury, also can affect blood glucose levels. The need for performance of or assistance with diabetes care tasks will vary from student to student. Many students will be able to handle all or almost all of their routine diabetes care by themselves. They can check their own blood glucose, and they can dose and give their own insulin or medication, keeping it in balance with physical activity and food intake. Some students, because of age, developmental level, or inexperience, will need help from the school staff, including performing tasks like insulin administration, blood glucose monitoring, or carbohydrate counting. Students who are experiencing diabetes distress, diabetes burnout, or depression may benefit from additional help and support. The symptoms of hypoglycemia vary from one individual to another. Also, they may vary for one individual from one episode to another. The symptoms of mild to moderate hypoglycemia are the first alert that the body is in a state of sugar deficiency. Symptoms may include the following: extreme hunger, yawning, sleepiness, shakiness, irritability or frustration, changed behavior, weakness, extreme tiredness or fatigue, sweating, paleness, anxiety, dizzy or lightheadedness, dilated pupils, increased heart rate, restlessness, confusion, or sudden crying. Mild to moderate hypoglycemia can usually be treated easily and effectively. Most episodes of hypoglycemia that will occur in the school setting are of the mild type. However, if not treated promptly, a mild hypoglycemic reaction can quickly progress to a severe state or condition which may be characterized by severe cognitive impairment and will require assistance in treatment. Inability to swallow, unresponsiveness, unconsciousness, seizure activity or convulsions are all symptoms of hypoglycemia that will require assistance in treatment. Remember, onset and progression can happen very quickly. Each student will have his or own set of symptoms that characterize hypoglycemia. These should be listed in the DMMP. The important thing to remember is that early recognition and intervention is the best strategy to prevent progression to more severe symptoms. The onset of severe hyperglycemia and progression to DKA is usually pretty slow. As a result, the recognition and treatment of mild hyperglycemia is vitally important. The following symptoms vary somewhat from individual to individual or from episode to episode and can include thirst, blurred vision, lack of concentration, weight loss, frequent urination, sweet or fruity breath, fatigue or sleepiness, stomach pains, increased hunger, and flushing of the skin. The following symptoms indicate that hyperglycemia has escalated. These symptoms include dry mouth, stomach cramps, nausea and vomiting, or sweet, fruity breath. The last group of symptoms indicate severe hyperglycemia and probable ketoacidosis. Labored breathing, confusion, profound weakness, and unconsciousness. The important thing to remember is that intervention of any of these levels will prevent progression to more severe symptoms. The school nurse is the most appropriate person in the school setting to coordinate and provide care for a student with diabetes. Many schools, however, do not have a full-time nurse. More often, school nurses cover a large number of schools. Even when a school nurse is assigned to a school full-time, he or she will not always be available during the school day, during extracurricular activities, or on field trips. Because diabetes management is needed 24 hours a day, 7 days a week, and diabetes emergencies can happen at any time, a student will always need access to diabetes care at school and at all school-sponsored activities. The DMMP details the specific conditions for all routine and emergency diabetes care tasks, including insulin and glucagon administration. Non-medical school staff can be trained to assist students with these tasks as laid out in the DMMP. However, any and all clinical assessments are made by the student's healthcare providers in the development of the DMMP. School staff are simply following the plan as prescribed. As a teacher, you can help by supporting self-care by capable students, providing easy access to diabetes supplies, ensure students eat snacks at scheduled times and make sure snacks are available to treat low blood sugar, provide students reasonable time to make up missed homework or tests, learn about diabetes and comply with the individual student's 504 and healthcare plans, and support diabetes care by providing free access to bathrooms and water during class. Other classroom tips include keeping a contact sheet of trained diabetes staff at your desk for emergencies, creating a diabetes info sheet for substitute teachers, learning the signs and responses to low and high blood glucose levels, educate your students about diabetes, and also let parents know in advance changes to the class schedule, including field trips or special events.